All right, welcome to the deep dive. Today, we're going deep, really deep into neuroimaging.
Ooh, sounds intense.
It is. But also super fascinating. We're talking about the techniques that are like the backbone of neuro-ophthalmology.
Couldn't agree more. Essential tools.
Absolutely. So we're going to break down CT scans, MRI, all sorts of angiography, MRA, MRV, you name it. We'll look at how they work, why they're so crucial for diagnosis, and, figuring out the best way to manage those tricky neuro-ophthalmic cases.
Exactly. It's all about understanding the strengths and limitations of each technique. What can they really show us, and what might they miss?
Right. So are you ready to dive in?
Let's do it.
Okay. Let's start with CT scans computed tomography. Can you give us like a quick refresher on how this actually works?
Sure. So with CT, we use X-rays, right? But instead of a single picture, we're basically taking a whole bunch of X-rays from all these different angles around the patient. And then a computer takes all that data and creates slices cross-sectional images based on how much those X-rays are absorbed by different tissues.
Oh, so it's about how dense the tissues are. That makes sense.
Yeah, and you get this grayscale image. So really dense things like bone, they show up bright white. Air, on the other hand, it's black. And then everything else falls somewhere in between.
Okay, so it's a density map. We've all seen those classic CT images. I remember when I first started, I was kind of blown away by how much you could see.
Oh, for sure.
Oh, yeah.
And the technology keeps getting better and better.
That's what I was thinking. CT has come a long way. What kind of advancements have really impacted, what we can see, especially when it comes to those subtle neuro-ophthalmic issues?
No, one of the biggest things has been the ability to get much thinner slices. Think about it. Thinner slices mean you can see finer details. It's all about improved spatial resolution. And what's amazing is that we've gotten faster scan times and better resolution without increasing radiation dose.
Okay, so that's a huge plus, especially for those cases where you really need to see tiny structures. How does the whole image acquisition and manipulation process work? I know we can look at the images from all different angles, even though the scan itself is done in one plane.
Right. So the standard way to acquire CT images is axially, which means, like slicing a loaf of bread. But the beauty of modern CT scanners is that they can do something called multiplanar reconstruction. The computer takes those axial slices and essentially reformats them so we can see the images in, like coronal, sagittal, or even oblique views. Super helpful.
So we can dissect the anatomy in all these different planes without having to reposition the patient.
Exactly. And in some cases, this ability to reconstruct the images gives CT an edge over MRI, especially when we need to really scrutinize like bony details, for trauma or things like that.
Yeah, bony detail is definitely where CT shines. And I think we all appreciate the fact that it's generally pretty readily available, relatively inexpensive and fast. In a busy clinic or, God forbid, an emergency, those are major advantages.
Absolutely. Speed and accessibility are huge strengths. But of course, we always have to consider the elephant in the room, which...
Radiation.
Exactly. Even though the doses have been optimized with newer scanners, it's still ionizing radiation. We're always weighing the benefits against the risks, especially when it comes to kids or patients who might need repeated scans.
Right. That's a constant balancing act. Now, I know we often use contrast agents with CT. Can you explain why we use iodinated contrast and what specific information it gives us, especially in neuro-ophthalmology?
Sure. So when we inject iodinated contrast intravenously, it basically lights up blood vessels. And any tissues where there's increased blood flow or breakdown of those normal barriers, like the blood-brain barrier.
Oh, so it helps highlight areas that are actively inflamed or maybe have tumors?
Exactly. It can help us see the margins of a tumor more clearly or distinguish an infection from normal tissue. It basically increases both the sensitivity and specificity of the CT findings.
Okay, but I'm guessing there are times when using contrast is a no-go, right?
Absolutely. The obvious one is a known iodine allergy. And if a patient has kidney problems, we have to be cautious because the kidneys are responsible for clearing that contrast out.
Makes sense. Are there any other situations where we might hold off on using contrast?
Yeah, definitely. So if we suspect a patient has a really acute hemorrhage, like a fresh bleed, the contrast might obscure the blood, which already shows up bright white on CT.
Ah, so it can make the bleed harder to see. Interesting.
Right, and similarly, if we're evaluating a bony injury or looking for a foreign object, say a metal fragment or something in contrast usually isn't necessary. It might even hinder our view.
Okay, that makes sense. So let's tie this all back to neuro-ophthalmology. When is CT our go-to imaging modality, and what are we specifically looking for? I know the outline mentions figure 19.1, which I think has some examples.
Figure 19.1 is a great visual guide. So, starting with trauma, like a blow to the eye, CT is king. We need to know if there are any fractures, especially those blowout fractures where the orbital contents can herniate into the sinus. Figure 19.1a shows that perfectly. And of course, we're looking for blood and any signs of air where it shouldn't be.
Right, makes perfect sense. What about thyroid eye disease?
So figure 19.1b shows what we often see in thyroid eye disease, those enlarged extraocular muscles. CT can definitely show us that increased muscle bulk, and it's often used as the first step in assessment. But keep in mind, MRI is often complementary here because it gives us better soft tissue characterization.
Okay, so they kind of work hand in hand. Now, what about orbital tumors? Figure 19.1c, I think. What advantage does CT give us there?
The big thing with orbital tumors is that CT is really good at showing us if there's any bone involvement. Is there erosion, destruction, or maybe even new bone formation? That can really change how we approach the tumor. And honestly, CT often does a better job of showing that bony detail than MRI.
Right, because MRI is more about soft tissues. What about orbital cellulitis? What does CT tell us there?
With cellulitis, we're worried about how far that infection is spread within the orbit. CT can show us that. And crucially, it can help us detect if there's a superiosteal abscess that's a collection of pus that needs to be drained surgically.
Okay, that's critical information. The outline also mentions intraorbital calcification. When do we see that in neuro-ophthalmology?
So some tumors, like meningiomas or retinoblastomas, can have calcifications. And those show up really bright on CT because of their density. It can be a big clue that helps us make the diagnosis.
It's like a beacon saying, hey, look here.
Exactly. Now, this might surprise you, but CT is also really good for detecting acute cerebral or subarachnoid hemorrhage. That's figure 19.1d. I think a lot of people assume MRI is better for bleeds, but it depends on the timing.
Oh, that's interesting. So when is CT better?
Well, in those very first few hours after a bleed, blood actually shows up more clearly on CT. It's super dense. MRI can be a bit less sensitive in those very early stages.
Yeah. Wow, that's something I didn't know. Okay, last question on CT. When do we choose CT specifically because we can't use MRI?
The classic scenario is when a patient has a metal implant or, say, the metallic foreign body somewhere in their body. We have to be really careful with those because the strong magnetic field of the MRI scanner could cause the object to move, which can be dangerous.
Right, so if there's any concern about metal, CT is the safer option.
Exactly.
Okay, that was a super helpful overview of CT. Let's shift gears now and talk about magnetic resonance imaging, or MRI. Can you explain the basic physics behind MRI? I know it's completely different from CT.
Totally different. So CT is all about X-rays and density, right? MRI, on the other hand, uses a completely different principle. It exploits the behavior of hydrogen protons, those tiny particles in the nucleus of an atom.
Vaguely, it's been a while since chemistry class.
Well, the key is that these protons are abundant in water and fat, which are like everywhere in our tissues. And when you put those protons in a strong magnetic field and then hit them with radio frequency pulses, they do this cool thing. They align themselves temporarily. And then, as they relax back to their normal state, they emit a signal.
Okay, and that signal is what the MRI machine picks up.
Right. The machine has these coils that detect those signals, and then a computer processes all that information to create those detailed cross-sectional images we see. And of course, the big advantage here is that there's no ionizing radiation involved.
That's definitely a huge selling point, especially for kids or patients who might need multiple scans over time.
Absolutely.
Yeah.
And just like CT, MRI can also acquire images in different planes directly. We don't always have to rely on reconstruction. So axial, coronal, sagittal, we can get those images from the get-go.
Got it. Now, let's think about T1 and T2 weighting. I hear those terms thrown around all the time, but I'm not sure I fully grasp the difference.
All right, so T1 and T2 are basically different ways of manipulating those radio frequency pulses and magnetic gradients. They highlight different tissue properties, which is why we use both.
Okay, so what's the difference visually? What am I looking for?
So T1 weighted images are great for seeing normal anatomy. Think of it this way, P1 for anatomy. Fluids, like CSF in the brain or the vitreous humor in the eye, they look dark on T1. Fat, on the other hand, is bright. And gadolinium contrast, if we use it, also shows up bright on T1.
So T1, dark fluid, bright fat, bright contrast. Got it.
Perfect. Now, T2 is kind of the opposite when it comes to fluids. On T2, fluids are bright. And that's really helpful for seeing pathology because things like edema, inflammation, basically anything with more water content, it's going to be bright on T2. Bone, which is super bright on CT, it actually looks dark on standard MRI.
Okay, so T2, bright fluid, good for seeing abnormalities. That makes sense.
Exactly. T2 for pathology. And keep in mind, these are just the basics. There are so many other pulse sequences and variations that we use to fine-tune what we're seeing.
Right, it's a whole world unto itself. Now, just like with CT, we sometimes use contrast agents with MRI. Can you walk us through how gadolinium-based contrast works and when we might use it in neuro-ophthalmology?
Of course. So gadolinium basically enhances the signal on T1-weighted images. It makes things brighter. But the key is that it tends to stay within the blood vessels unless there's a breakdown of the blood-brain barrier. So if we see an area that's brighter after we inject gadolinium, it suggests there's some sort of abnormal leakage, like in a tumor or an area of inflammation.
So it helps us pinpoint areas where something is going on, right? And the outline mentions figure 19.3a and b, which show this.
Yeah, those images are great examples. 19.3a shows meningiomas before contrast, and then 19.3b shows them after gadolinium. You can see how they really light up, making them much easier to see.
That's incredible. Now, you mentioned fat being bright on MRI. I see that the outline talks a lot about fat suppression techniques, especially for orbital imaging. Why is that so important?
Ah, yes, fat suppression. So think about the orbit. It's surrounded by a lot of fat. And remember, fat is super bright on T1-weighted images. That brightness can actually obscure the things we're trying to see, like the optic nerve or the muscles.
Ah, so it's like trying to see a star right next to the sun.
Perfect analogy. Fat suppression basically turns down the brightness of the fat so we can see those other structures more clearly.
And we have different techniques for doing that, right? Like T1 fat saturation with gadolinium and STI.
Yep. So T1 fat sat with gadolinium is great because it does two things at once. It suppresses the fat, making it dark, and it enhances anything that's taking up the contrast. Figure 19.3c, which shows orbital lymphoma, is a great example. The fat is nice and dark, and then you see the muscles and the tumor surrounding the optic nerve sheath really clearly.
Wow, that's a striking image. What about SDR short T1 inversion recovery?
So S-star is another really useful fat suppression technique. It not only gets rid of the bright fat signal, but it also highlights areas with a lot of water. So it's super sensitive for detecting abnormalities within the optic nerve itself. Figure 19.3d shows an optic nerve glioma, and you can see how it just pops out against that dark background. And figure 19.3e shows optic neuritis, same idea.
So if we suspect a problem within the optic nerve, S-star is our friend.
Pretty much. Now, another technique you'll often hear about is flare fluid attenuated inversion recovery. This one is a bit different. It suppresses the signal from cerebrospinal fluid, which is normally bright on T2.
Okay, so why would we want to do that?
Well, sometimes we want to see things that are right next to CSF spaces. For example, in multiple sclerosis, you often get these plaques of demyelination around the ventricles of the brain. FLAIR helps us see those plaques more clearly because it gets rid of the bright signal from the CSF.
And figure 19.3F shows that, right?
Exactly. You can see those periventricular plaques really nicely on FLAIR.
Okay, and I see the outline also mentions some more advanced techniques like D-Way DC and fiestasis. Can you give us the quick rundown on those?
Sure. So diffusion-weighted imaging, or DWI, looks at how water molecules move within tissues. It's really helpful for detecting things like acute stroke because it can pick up those changes very early on. And then ADC, which stands for apparent diffusion coefficient, that's basically a map that helps us interpret those DWI images. Fiesta and CISS, those are techniques that provide really high-resolution images of fluid-filled spaces. They can be helpful in neuro-ophthalmology for visualizing the cranial nerves, especially for trying to figure out why someone has a cranial nerve palsy.
So MRI gives us all this amazing detail, but I know it's not perfect. What are the limitations we need to keep in mind?
Right, so one thing to remember is that MRI doesn't visualize bone as well as CT does. Bone is pretty much invisible on standard MRI sequences. And like we talked about earlier, it's not always the best for hyperacute hemorrhage. Those early bleeds can be tricky.
And of course, there's the issue of metal.
Right, if a patient has a pacemaker, certain types of aneurysm clips, or any other ferromagnetic implants, MRI is off the table. It's just not safe.
And there's the claustrophobia factor.
Yeah, MRI scans can take a while and you're in this enclosed space. For some patients, that can be really tough.
Definitely something to consider. So let's talk about when MRI is the preferred choice in neuro-ophthalmology. When do we reach for MRI first?
Well, anytime we suspect a problem with the intracranial visual pathways, the optic nerves, the chiasm, the TRAX MRIs are go-to. It's just much better than CT at showing us those structures and any abnormalities within them.
Okay, so if we're thinking optic nerve, chiasm, tracks MRI, it is.
Pretty much.
Yeah.
And if we're specifically looking at the optic nerve itself, there are a few key sequences we use. Coronal STIR, that's really good for showing us anything within the nerve. And then coronal and axial T1 weighted images, with and without contrast, those help us look for enhancement, which can be a sign of inflammation, tumor, or other problems.
So a combination of sequences gives us the most complete picture.
Exactly. And we can't forget about axial T1 images. Those are good for seeing the normal anatomy of the nerve.
Okay, and what about optic nerve sheath meningiomas? How do those look on MRI?
So meningiomas often have a similar signal to the nerve itself on T1 and T2 images, but they usually enhance really brightly after contrast, which is a big tip-off.
So contrast is key there.
Definitely. Now, another common issue in neuro-ophthalmology is cellular masses, like pituitary adenomas. MRI is the best way to evaluate those.
And what sequences do we use for those?
For cellular and paracellular lesions, contrast-enhanced T1-weighted images are the gold standard. Coronal views are essential for seeing the contents of the cella and the surrounding areas. And we usually get sagittal views as well, just to get a complete picture of the tumor's size and location.
Makes sense. And what about when we suspect something's going on in the cavernous sinus? That can affect the cranial nerves that control eye movements?
For the cavernous sinus, high-resolution coronal MRI images are what we want. And we often need contrast to really see what's going on in there, especially if there's a problem with the nerves or blood vessels.
Okay, so high-res coronal MRI, possibly with contrast. Got it.
Yep. And then for any intracranial lesions that might be affecting the visual pathways, whether it's inflammation, demyelination, a tumor, or a vascular problem, MRI is always going to give us more information than CT. It's just better at showing us those soft tissues and the anatomy of the brain.
Okay, that's a super comprehensive overview of CT and MRI. Now let's move on to angiography. I know this can be a bit confusing because there are so many different techniques: MRA, MRV, CTA, CTV, and then conventional angiography. Let's start with magnetic resonance angiography, or MRA. What's the basic idea behind MRA, and how does it help us in neuro-ophthalmology?
So MRA is basically a way to visualize the arteries in the head and neck, both inside the skull and outside. It's really helpful for seeing the blood vessels that supply the brain and the eyes. Figure 19.4a gives you a good visual.
Okay, so we can see the carotid arteries, the vertebral arteries, all their important players.
Exactly. And MRA can show us if there's any narrowing, blockage, or even aneurysm. And the nice thing is that it's non-invasive. We're not putting any catheters or anything like that into the patient.
Right, that's always a plus. But I'm guessing there are limitations, right?
Of course. Because MRA relies on blood flow to create the images, it might miss things like a completely blocked artery or a clot that's not moving. And sometimes, turbulent blood flow can make the images hard to interpret.
Okay, so it's not perfect. And what about really tiny aneurysms? Can MRA always pick those up?
They can be tricky. Small aneurysms can sometimes be missed on MRA, and we should remember that adding an MRA sequence usually adds about 10 minutes to the overall MRI exam.
Okay, good to know. Now, what about magnetic resonance venography, or MRV? Is that basically MRA but for veins?
You got it. MRV is all about the veins. It's especially helpful for looking at the dural venous sinuses, those big veins that drain blood from the brain. Figure 19.4b shows a dural sinus thrombosis, which is basically a blood clot in one of those sinuses.
And that can be a serious problem, right?
Absolutely. It can lead to all sorts of neurologic problems, including vision loss. Historically, we use conventional angiography to diagnose these, but MRV is much less invasive.
Right, much less invasive. So MRV has become a really important tool for neuro-ophthalmologists.
Definitely. And with all the advances in MRI technology, the images we're getting from MRV are just incredible. We can see those veins so clearly.
Amazing. Now let's switch over to CT-based angiography. First up, we have computed tomographic angiography, or CTA. What are the big advantages of CTA, especially in our field?
So CTA has become the go-to for looking at intracranial aneurysms. That's figure 19.4c. Basically, we inject contrast, just like with a regular CT scan, but then we acquire the images very quickly, getting these super thin slices. And then the computer can create these amazing 3D reconstructions of the blood vessels.
Ooh, that sounds impressive. So we can see the aneurysm from all angles.
Yep. It's super helpful for surgeons if they need to click the aneurysm, or for interventional radiologists if they're doing a coiling procedure. And CTA is really fast and safe. It doesn't carry the same stroke risk as conventional angiography.
That's a big plus. Now, what about computed tomographic phonography, or CTV? How does that stack up against MRV for looking at the cerebral veins?
So CTV is another good option for imaging veins. It's also really fast and provides high-resolution images. And one nice thing is that it's less susceptible to motion artifacts than MRV. So if a patient has trouble staying still, CTV might be a better choice.
Right, that makes sense. So when would we choose CTV over MRV?
Well, both techniques are good for detecting cerebral venous thrombosis, but sometimes CTV can pick up things that MRV might miss, or vice versa. They can be complementary. But keep in mind, CTV does involve radiation and contrast. And sometimes the bony structures at the base of the skull can create some artifacts on CTV, making it a bit harder to see those veins compared to MRV.
Okay, so there are trade-offs with each technique.
Always. The key is to choose the best tool for the specific situation.
Right. Now, last but not least, let's talk about conventional catheter angiography. This seems like a more old-school approach.
It is. It's definitely more invasive. So with conventional angiography, we actually insert a catheter into an artery, usually in the groin. And then we thread that catheter all the way up to the arteries in the head and neck under X-ray guidance. Then we inject contrast and take a bunch of X-ray images.
Wow, that sounds like a pretty big deal.
It is. It's done under local anesthesia, but it does carry a small risk of complications, like stroke. Figure 19.4D shows what those images look like. You can see the blood vessels really clearly.
So when is conventional angiography still necessary?
Well, honestly, with the advancements in CTA and MRA, we don't use it as much as we used to. But sometimes those non-invasive studies might be inconclusive, or we might need to do a procedure like placing a stent or coiling an aneurysm. In those cases, conventional angiography is still the gold standard.
Okay, so it's still a valuable tool in certain situations.
Absolutely.
All right, this has been a whirlwind tour of neuroimaging. To sum it all up, can you give us the key takeaway points for our neuro-ophthalmology colleagues? What are the strengths and weaknesses of each technique?
Sure. So for CT, it's all about speed, accessibility, and that excellent bony detail. It's great for trauma, acute bleeds, and seeing calcifications. The downside is the radiation. MRI, on the other hand, is all about soft tissue contrast. It's the best for looking at the optic nerves, the brain, and the orbit. No radiation, but it's slower, more expensive, and not for everyone, especially if there's metal in the body.
Perfect summary. And for angiography, it seems like we have a whole toolbox to choose from.
Exactly. We've got MRA and MRV for non-invasive imaging of arteries and veins. CTA is really good for aneurysms. CTV is another option for veins, but it does involve radiation. And then we have conventional angiography, which is the most invasive, but still has its place in certain scenarios.
It's amazing how far imaging technology has come. It makes you wonder, what's next? What new advancements are just around the corner that will, change the way we practice neuro-ophthalmology? It's definitely something to think about. Thanks so much for joining us on the deep dive. This was incredibly insightful.
My pleasure. It's always fun to talk about these things.
All right, that's a wrap.
Until next time.
See you later.